the much awaited panel discussion, and we have the elite panelists with coming in Dr. Balasubramanian sir, SBS sir, there as the moderator for the session, and I welcome you, sir, for the 5th annual national conference and this panel discussion. Also, we have other panelists. Yeah, Dr. SBS sir requires no introduction, but again, as a formality, he'll just run through. He is a visiting consultant in pediatrics and former medical director.
Krishna, I have already been introduced yesterday. Don't worry. Take time.
Yes, sir. Thank you, sir. And the next panelist we are coming in is Dr. Ashwath Duraiswamy. Dr. Ashwath Duraiswamy is a consultant pediatrician at Kovai Medical Center and Hospital, Coimbatore. He is also consultant pediatrician at City Center of Kovai Medical Center and Hospital, visiting the Faculty of Pediatrics at KMCS Nursing College. He has numerous papers to his credit, has been awarded at various forums, national and international forums, as well as an ardent speaker at various forums. Welcome, sir, Dr. Ashwath, sir. Also, we have Dr. Professor Ashwani K Sood. Is a medical superintendent and professor of pediatrics from the Maharshi Markandeeshwar Institute of Medical Sciences, Haryana. He has held various positions: president, HPNNF, president, Haryana State Chapter, chairman, advisory board for pediatric TB under NTF on NTEP. He is the vice chair, IIP Infectious Disease Academy 2020. He is also the EB Central IAP 2011 and 13, president, HP IAP 11 and 12. He has numerous papers to his credit, and his areas of interest include infectious disease, immunology, infant nutrition, quality in healthcare, and medical education. Dr. Ashwani, sir, welcome on board. Next, we have our Dr. Jaydeep Choudhury, sir, Professor, Department of Pediatrics, Institute of Child Health, Kolkata. He is currently the Vice President, EZ Central Chapter 2019, Chairperson, IAP Infectious Disease Chapter 2020, Convener, ACVIP 2015-16. He also has numerous papers and books to his credit. Welcome you, sir. Sir, with this, the session is open to SBS, sir. Thank you, sir.
Thank you, Krishna. Let me share my screen. Okay. Yeah, is my screen okay and my audio okay, Krishna?
Yes, sir.
Yeah, thank you very much to Dr. Manjula, Krishna, and all others, the FEAR Foundation, of course, Dr. Jagdish. We are going to have a very light discussion after a lot of, brainstorming sessions. What are we going to do over the next 40 to 45 minutes? Basically, for pediatricians in office practice, we see different types of practice, different types of fever, different etiologies for fever. But I'm going to narrow down to some different types of fever suitable for practitioners. And then I'm going to put some case scenarios to our three very distinguished faculties, Dr. Ashwani Sood, Dr. Jaydeep, and Dr. Ashwath. In these case scenarios, there will always be dilemmas in decision making. Let's see what the experts have to say on it. Let us hear their verdict. And of course, we will summarize and give you some take-home messages. For a pediatric practitioner, if you ask me what are the types of fever you get, student might say remittent fever, intermittent fever, continuous fever, Bell-Epstein fever, biphasic fever, etc., etc., etc. I think all those types of patterns of fever are rarely important in practice. So there are only 4 problems related to fever that a pediatric practitioner in office practice comes across. The most difficult one is the first and the last. The first is fever without focus, short duration. You may get frightened when there is nothing serious, or you may not react when there is something serious. Both can happen. The easy bread, butter, and jam, short duration fever, most of them resolve. They don't give us much headache. Fever more than 1 week, within 2 weeks, most of us are able to solve it by treating it as enteric fever or scrub typhus, and we get away with it, majority. The last difficult one is the PU. These are the 4 types which I thought we should stratify in practice. Let us take the most difficult scenario. In fact, I often find it very difficult to handle any infant or a young child who comes without focus, with a very high temperature. Parental anxiety is very high. You also don't know at times what to do. Let us look at this scenario. 4 months old, fever only for about 12 hours. The mother has documented the axillary temperature with the digital thermometer, 103. No other signs. Birth weight was 3 kg, growing reasonably well, 4.5. Mother has correctly given the correct dose of paracetamol. The fever comes down, goes up, again shooting up. This is a frequent scenario. Now, I'm going to ask Dr. Ashwani Sood to start with. In this scenario, how do you manage, Dr. Ashwani Sood? How do you manage?
Good afternoon, everyone. Am I audible?
Yes, Ashwani.
Yeah, thank you, the Fever Foundation. And this is an interesting scenario. And if I want to say, this could be the number of cases around 60 to 70% in day-to-day practice of all our colleagues. So before I would like to proceed, I would like to know that one is immunization. Second, I would like to know that what is the feeding pattern, whether this baby is being exclusively breastfed or on top feed or mixed feed. And definitely, I would like to know that what has been the activity of this child, because I would like to categorize him fever without toxic look or fever with a stable child, because my further management will depend on this. If a child is playful, he is accepting the feeds, I'll just discuss out with the parents to wait and watch to maintain a temperature diary. Give optimum dose of paracetamol that can be repeated as early as up to 4 hours if we are getting a delay response after 6 to 8 hours. And if it is a toxic one, then definitely 4-month-old, I won't take a chance. I'll admit him and send his investigation and start on empirical antibiotic, which we are going to discuss later on.
Okay, now.
And then like to ask them to come after 3 to 4 days.
Okay, now.
If it's a stable child.
Would you admit this child or treat it as OP? See, baby is breastfed, baby except for fever and a little bit of fussiness is otherwise.
Based on his look, if it is a toxic, I will definitely admit.
How will you decide the child is toxic?
That I will look into his hemodynamical stability.
Everything is normal except fever.
Yeah, then I'm not going to admit him. I just discuss with the parents. Because most common is we see the viral. And the one thing which I forgot to tell you, I would like to elicit history of viral illness in the family also.
Okay, now I want to ask the others. Dr. Jaydeep, what are the common causes you have seen in your experience? Fever without localizing signs. And again, I'll add one more question to you, Dr. Jaydeep. Do you have a strict protocol or individualized approach depending on the patient's socioeconomic status, educational status, whether it is the first time they are coming to you or if they are regular patients for you? Dr. Jaydeep.
Yes, sir. Good afternoon.
Common ones you have seen in your practice.
Yes, sir. Yeah, good afternoon. Now, just can I make a comment about this child that you are discussing also?
Yes, yes.
Yeah, basically, sir, this child is a 4-month-old infant.
Yeah.
So I will be a bit cautious because of the severe bacterial infection, or SBI that we call, because 30% do present with fever, and an infant presenting with fever, I will be a bit cautious with this child. So first of all, if the fever is documented, if the fever is documented and the child needs observation, it's better to admit the child. But if the fever is undocumented, then we may just ask them to document the fever and come back if the child is looking well and stable.
Okay.
Otherwise, it's always better for investigation. And regarding the causes of, if you say that in an infant, you mean the fever without focus? Sir, in an infant, the causes you want to discuss?
No, so you also would admit this child. Am I right, Dr. Jaydeep?
I will admit this child because
Okay.
see,
Let's move on to Dr. Ashwath. You would admit or treat it as OP, Ashwath. And when will you
I would.
treat it as OP?
Good afternoon. I would probably evaluate this baby before I decide one way or the other.
Yeah. How will you evaluate? What will you do to evaluate Dr. Ashwath?
So the first thing is it's a very young infant. So bearing in mind the possibility of this child having an invasive bacterial infection or serious bacterial infection, which is what we don't want to miss. I will look at the wellness of the child. Is the child interacting well with the caregiver? Is the child breathing normally? Is the capillary filling time normally? Is the child sucking well at the breast? Is the child passing out enough fluid? If the three B's, the behavior, the breathing, or the bleeding, or the blood pressure are abnormal, and be very careful. So for me, the starting point is the wellness or the sickness of the child. Well child, fever without focus, immunized, thriving well, breastfed, appearing happy except for fever, I'll be very happy to evaluate the baby with basic investigations and then take a call on admission rather than admit upfront and scare the parents.
Yeah, I'm happy that I created some controversy with two of the panelists saying they will admit and one panelist not agreeing. But then the problem here is that the protocols that are seen in textbooks and guidelines, again, they are not uniform. There is no uniform guideline for fever without focus anywhere in the world. It varies from geographical area to area. But I think all the three of the panelists agreed the infant is toxic and his child is having signs of sepsis. Yes, you give the benefit of doubt, admit, investigate, and then give IV antibiotic. In case the infant is not toxic, even if it is not toxic, even if there are no signs of sepsis, if the infant or the young child, particularly below 3 years, is a known case of immunodeficiency, for example, HIV or hypogammaglobulinemia, yes, you will definitely evaluate, do cultures, and probably err on the side of giving IV antibiotic. The infant is not immunocompromised, is over 24 months. Generally, the risk of serious bacterial infection comes down. Then you go by the physical finding. That is where what Dr. Ashwani K Sood said, the baby is otherwise well, active, nothing is happening, over 2 months, not 4 months like this. Then if there are no physical clues, you can even wait and watch. If the child is less than 24 months, you always look for an obvious source of infection. It could be as simple as otitis media, as simple as some paronychia or an abscess somewhere, as simple as something like a pneumonia where you can make out some tachypnea without fever or tachypnea out of proportion to fever. Then you go by the physical findings to manage. No source of infection, then you should look for UTI. In fact, one investigation which probably will be most important is a urine routine analysis. I put here risk factor for UTI. I would say any fever below 3 months is a risk factor for UTI. At least urine analysis routine should be done. In the slightest doubt, you should do a urine culture and treat based on reports. And if it is unimmunized, then again, err on the side of investigating and giving antibiotics. Completely immunized, child is well, above 24 months, you don't do anything. This is an algorithm which is practical. In fact, I'm going to ask again, Dr. Ashwath and Dr. Jaydeep, do you have a strict protocol for this or you individualize? Say it is educated patient, you have a protocol. Uneducated patient, rural patient, you have protocol. Do you have like that? Or first time visitor, you have a protocol? Do you have like that? I'm sorry, sometimes I've seen doctors following that. What's your comment on it?
So since we have postgraduate students training with us, we are very keen that we disseminate some sort of rational concepts and approach to fever in the different age groups. So we teach them again and again to go back according to the pediatric assessment triangle first. If you identify anything life-threatening or if you see abnormalities in the appearance of the baby, the behavior of the breathing pattern, then we proceed with admission, speedily evaluate the child for a probable bacterial source and treat. On the other hand, that's a well-appearing child where the only problem is a fever without focus. After taking history, doing a thorough physical examination, our instruction is for them to stratify according to the age group. This child comes under the age group of 3 months to 36 months, and the child is thriving well. There is no localizing focus. The very minimum we would require the baby to have a CBC, a urine complete analysis, and a CRP before we decide one way or the other.
Okay.
Physical examination followed by some screening investigations for probable bacterial sepsis.
Okay. Now to Dr. Ashwani again.
Yeah.
What do you think are the red flags in such fever without focus or short duration fever, which I think it is our duty to train the parents to recognize? What are the most important red flags, Dr. Ashwani? You tell them that if this is there, you come call me back, you go to hospital, get admitted. How do you advise them? What are the red flags you teach the parents, Dr. Ashwani?
So I'll start from the lethargy which we come across in this age group. That's very common. That's why I try to look into the eye contact to the patient. If there is some issues with the feeding pattern, or if baby is going to be losing the consciousness. In addition to that, if baby develops seizures or abnormal body movements, or there is appearance of rash, as we are seeing a number of patients these days, and as you rightly pointed out, whether fast breathing, and in fast breathing, if it is going to be the distress of which extent, then decrease urine output, and if there is any discoloration of sclera, jaundice, and in addition to that, if a baby is not accepting the feed at any time, even a single feed miss, 4 months old, I would like to tell them to rush to the hospital in the emergency.
So do you give any temperature point as a red flag to parents? Do you give any age as a red flag for fever, Ashwani? So I have specifically not mentioned here, but I want to ask you.
Definitely there are two issues. One, we definitely tell them to record the temperature, put a time, and also mention the dosing, because they need to be sure regarding the complete dosing of paracetamol. Plus, because we all know that if it's definitely a fever without focus, because as my co-panelists were discussing, that we have excluded urine abnormality, we have looked at ear is normal, there is no other sign right now, as we just only fever, then at least I can safely wait for 72 hours if this baby is feeding well.
Okay, if it's a neonate, you will always ask them to go to hospital. Am I right? If they call you over phone, the document.
If a neonate comes to me less than 3 months, I am not going to let him go back to the home. I'll admit him and watch him for 2 to 3 days.
Do you have any temperature point at which you would say you go to hospital? Because most of the parents will call you. Her temperature is 103.5. Will you tell them?
Not like that, because we try to look into that how much paracetamol they are giving, and then as I was sharing with you, we can reduce the interval, because some babies may only need paracetamol another dose after 4 hours even.
Okay. Now let's move on to our breadwinner, short duration fever. 2-year-old fever for 3 days. The fever is going up. Severe cough and cold. Parents visiting you daily. They are a very anxious, precious child. And paracetamol, cetirizine, and some saline nasal drops. How often do you give antibiotics in such a situation? And rising trend, day 3 fever. How often will you consider giving antibiotics? And when will you give antibiotics? Dr. Jaydeep.
Yes, sir. 2-year-old fever for 3 days. Important point is rising trend. Now, most often the viral fever starts with very high fever, then it persists for 2 to 3 days. Then it usually shows a falling trend. Number two, cough and cold are not very specific. Definitely, this child needs an upper respiratory examination, including an otoscopy. Or if there is obviously ER discharge, then it's okay. Third is regarding the respiratory system. So empiric antibiotic for 3 days fever, even if rising trend, it's no. Because without any other focus other than cough and cold, it's likely to be a viral fever and we can wait for 5 days. But of course,
even if it is mucopurulent discharge, day 3, will you consider antibiotics or not consider?
That's what I am coming. Of course, if there is any ER discharge, if there is mucopurulent discharge, or if there is some findings in the chest like crepitations, then definitely I will start antibiotic because it's a rising fever beyond 3 days.
Okay, now to Dr. Ashwath. Dr. Ashwath, you are a very seasoned practitioner in Coimbatore. When do you give antibiotics in your practice empirically, either with investigations or without investigations, without waiting for investigation reports? And how often do you do that? What are the classic examples in which you would give antibiotics, say without investigations for fever, or you send some investigation and start antibiotic? Can you give examples, Ashwath?
Sure, sir. I think there are two issues here to be considered. When there is a choice of empirical antibiotics for fever, one is the probability of this disease being a bacterial infection should be high enough to justify antibiotics. Two, I have to give antibiotics upfront even without waiting to confirm the cause, which means there is an element of urgency. So when is it possible? If the classical clinical features are very consistent with a presentation, a child comes with fever, the child has odynophagia, dysphagia, the child has a toxic appearance, tender cervical lymph nodes, I can see a membrane on the tonsils. I would not do any investigations. I'll probably initiate amoxicillin at 50 milligram per kg. Here the diagnosis is obvious. I need not do any investigations in a run-of-the-mill case. Two, if there is a high probability of a bacterial infection, but the child is in an immunocompromised status where waiting would be dangerous. Let us take the example of a child who's an acute lymphoblastic leukemia patient who's currently on chemotherapy. Now, I know that this child is on chemotherapy, the child is likely to have a febrile neutropenic sepsis. In this situation, I would probably draw blood for cultures, urine counts, and then start antibiotics because of the potential for harm is more if I wait. Third, if a clinical situation, let us say the example of a child who is recovering from measles, if the child is brought with respiratory distress and the child has got focal or generalized respiratory findings, I'm almost always going to err on the side of antibiotics because I think it's a post-measles bronchopneumonia. These are just some examples where I will give antibiotics after drawing investigations or probably even without investigations.
Excellent, excellent. Very rarely only we actually resort to investigations in office practice for antibiotic. For example, as Ashwath mentioned, if there is an abscess, if there is acute bacterial tonsillitis, you don't even have to do any investigations. You can give antibiotics straight away. Otitis media, we don't do investigation. Some diseases like UTI, enteric fever, we ask for tests, we start antibiotic, wait for the confirmation. And as Ashwath said, febrile neutropenia, that's not often seen in practice, but you have a child with tachypnea suggesting pneumonia, meningitis, then you're going to admit, start antibiotic where waiting is dangerous. Some situations, you don't even ask for proof. Acute subcurative tender lymph nodes in the neck, softening. You're not going to get proof. You're not going to do aspiration, then start antibiotic. You're going to start antibiotic. Abscess, you're going to start. And as rightly pointed out by Ashwath, measles, fever goes beyond 7 days, 8 days. Secondary infection, pneumonia. Chickenpox fever more than 4 days might indicate soft tissue infection. And last but not the least, you have dysentery, blood in the stools, fever, tenesmus, sick child. You're not going to ask for stool culture and wait for the results before starting antibiotic. Let us move on to Dr. Jaydeep. Jaydeep, this is a child with fever for 1 week, 5-year-old. Parents have given azithromycin for 3 days. Cefixime for 2 days on the advice of a GP. Child is not getting better. Counts are 5,500, platelets normal, CRP 24, urinalysis normal. What do? Do you give antibiotics or no? Or you will say you can wait, child is not sick. Or if you decide to start antibiotic, what is your choice of antibiotic? Jaydeep.
Yes, sir. It's a fever for 7 days. So we cannot take it lightly because this fever is there for 7 days. The problem is that the child has taken azithromycin for 2 days. We are not sure about the dose. Usually it's a low dose that's given, and cefixime for 2 days. So 2 days cefixime will not serve much of a purpose, and particularly we are not sure about the dose. And 3 days azithromycin also is probably inadequate if we are thinking of, say, typhoid fever or something else. The child is not getting better. Total count is around 5,000, which is also low. Platelet is normal, CRP 24, urine normal. So what to do? Point is that this is a fever of unknown origin, as we say by definition, and it's also persisting for 7 days. Though the other causes like rheumatological malignancy and all we have to keep in mind, but most commonly and most probably this is a infection. So we have to do a good blood test, including the complete blood count, a bacterial culture. That's very essential. A chest X-ray is essential at this point of time. And
no respiratory signs, will you ask for an X-ray?
Yes, sir. Still we will, because it's a fever is persisting for more than 7 days. And at this point of time, we might think of doing a sputum or a gastric aspirate for AFB also, if we have any doubt. And then if we start an antibiotic, that should be an oral azithromycin, because the child is still not that sick that the child needs an injectable antibiotics. But investigation for infections has to be done and has to be complete at this stage before we jump to anything else.
Ashwath, your action at this point of time. You want to agree with Jaydeep, or I'm trying to create a divide among the panelists?
Yeah, Dr. Bala.
No, I think
in a lighter vein.
Yeah.
Yes, Ashwath.
Definitely, the child needs to have a relook. Going back to the history physical examination, as Dr. Jaydeep said, the cefixime duration is too short for us to draw any conclusion as to whether this be appropriate antibiotic or whether this dose is appropriate for the clinical illness. So these are the things. I'll revisit the history, reassess the child with physical examination, and then take a call whether I need to continue with the antibiotic.
Okay, the same child,
Dr. Bala.
Yeah, 1 minute. The same child, the parents show you a temperature chart, that the temperature over the last 7 days, maximum temperature has been 99.24 times once a day. What do you do, Ashwath?
I think I'll stop the antibiotics.
Absolutely. I think that's what of course, Dr. Jaydeep clearly mentioned, but I wouldn't do anything for this child. First thing is to revisit, ask them for a temperature chart. I can tell you 9 out of 10 cases, there won't be any temperature chart at all. They will say high fever, and fever would not have been checked even more than 2 or 3 times a day. Child will be playful. I think the best is that temperature chart before you go into it. Of course, if you have documented pyrexia for 7 days, there's absolutely no doubt you investigate. And in this child, Dr. Jaydeep says you start azithromycin. What is your choice, Ashwath?
So not azithromycin, I told amoxicillin.
Amoxicillin. Why amoxicillin for what?
No. If the child has any
what are you trying to cover with amoxicillin for 7 days?
First I told that antibiotics should not be continued and do all the investigation.
Absolutely.
Now, if at all we find some focus, like say that low total count, the CRP is borderline. If we at all have to start any empiric antibiotics, then it has to be amoxicillin and not azithromycin or cefixime. This was my
amoxicillin for 7 days fever. I don't know. The Ashwath and
Investigation is the first step. Investigation is the first. That's what I meant.
Okay. Let's move on to the fourth case before we enter into further arguments. This is a 10-year-old child who has fever for 2 weeks. Unlike the previous one, actually previous one, I can tell you, the temperature chart showed 99.4 for 4 days. I stopped everything. Next day, child was febrile. No antibiotics were given. The moral of the story, always check the temperature. Okay. Case 4. This is documented fever for 2 weeks and treated at several places, multiple antibiotic, only 5. Cefixime, amoxiclav, okay, 2 days of doxycycline, and then ceftriaxone for 3 days and quinolone, all for 3-4 days, hospitalized. And Dr. Ashwani, what will you do for this child? 2 weeks fever, multiple antibiotic. You have a lot of investigations, nothing is conclusive. How will you proceed? Dr. Ashwani Sood.
The first will be to look into the, as you rightly pointed out, that we will try to look into the fever.
Please go ahead.
What happens? Parents say that there's a fever or 2 weeks and do admit for a day or so. There's not even a spike of fever. Secondly, I do try to do a physical examination and try to look for the localization of, if I could get localization, starting from sinus tenderness, lymph node involvement, hepatosplenomegaly, or any other lymph nodes. I try to look into, or is there any rash. It's important in this because this patient has been given 4 sets of antibiotics. So I would like to correlate this illness to a particular time.
I think Dr. Ashwani's connection is good.
Sir, can I just make a comment on this?
Yeah, please go ahead, Jaydeep. Yeah.
Sir, it's a prolonged fever. One, we have to take the history of a good temperature record, whether the fever was persisting or whether it was small episodes of fever, 2 to 3 or 4 days duration. In between, the child was well, going to school, again developed fever. So these type of short duration fevers, which the parents often coalesce and make it a long duration fever, is usually due to recurrent viral infection that they acquire from school.
Okay.
If the fever is documented and persisting for a long duration, then definitely along with the medical history, routine examination, definitely a CBC smear, as you are showing in the algorithm. But one thing, my personal preference will be to do a chest X-ray and a sputum examination for tuberculosis ahead of any other investigations like USG or REST. And the tuberculin skin test I will not do. That I will not do, but rather I will go for AFB CBNAT. So this is, I think, and then sir, that's all.
Okay, Ashwath, how do you have admitted this child, Ashwath, 10-year-old, and you have decided to investigate? What is the protocol you follow in your practice? Ashwath? Hello?
I think he's also not there. You please continue, sir.
Ashwath, his connection is lost?
Yeah.
Okay. I think what Dr. Jaydeep said is extremely important. First is you check the temperature records. Second is to take a good history. In fact, many a time when I admit a PU in the hospital, I ask the junior most postgraduate to take a good history for about 45 minutes and I sit down and check. That's what you should do. Then, of course, complete examination from head to foot, lymph nodes, as somebody fundus examination, blood pressure, pulse check, everything has to be done. Of course, the basic ones are a complete blood count, peripheral smear, and of course, urinalysis, perhaps urine culture also. Blood culture is very important. Manto, older child is of less value, but if it is going to be positive, then it could, you can start targeting for tuberculosis, X-ray chest, ultrasonogram, liver function, and renal function test. In fact, Having done all this, do you start antibiotics, Dr. Jaydeep?
Dr.
And how
Ashwath
you
has
decide
joined.
to start antibiotic and which antibiotic you choose? PU, 3 weeks, like I mentioned here, this is 2 weeks fever, 10-year-old, absolutely nothing localizing, documented fever. You have done these tests and everything is borderline. Culture is awaited. What do you do?
An admitted child, if we do not find any focus and we have to start an antibiotic, then the first line should usually is ceftriaxone. But again, I would stress on the fact that if the fever is persisting, definitely all out effort should be there to determine the cause of fever, including tuberculosis, including tubercular meningitis that we have to think of. And beyond that, the non-infectious causes of fever should also be explored. Considering all the fact that, yes, if we have to start an empiric antibiotic, 10-year-old ceftriaxone will be the antibiotic of choice, but 100 milligram per kg, because otherwise, even if it's a clinical typhoid fever also, 100 milligram is the dose.
Would you add doxycycline or will you give ceftriaxone alone? Ashwath also.
Definitely scrub IgM I will do. And usually a scrub typhus patient, fever for more than 7 days usually becomes very sick. And if the child is very sick, then an empiric doxycycline is worth considering, because scrub typhus may deteriorate very fast. But other than that, if a stable child with the investigations ongoing and if the scrub IgM is negative, I will not start doxycycline because usually the sensitivity of scrub IgM is quite high, and specificity also.
Yeah, once you do a blood culture, I think you can be questioned in a court of law if you don't start antibiotic. Once you have suspected an infection, if you don't do blood cultures, you are very confident this is non-infectious, then it is different. Once you have done a blood culture, I think it is legally probably not appropriate if you don't start an antibiotic. And most of the time, based on epidemiological data, you decide on starting doxycycline or not. Dr. Ashwani K Sood had prepared this chart. Unfortunately, he couldn't join. But I will just sum up what is here. Basically, when you have fever for 4 weeks or more than 4 weeks, you have only 4 groups. One is infection, infection, infection. Second is inflammation, non-infective inflammation. You are vasculitis and collagen vascular disease. Third is the malignancy. Fourth is miscellaneous. So basically, you start working towards infection. And this is where, other than blood cultures, depending on the finding, like lymphadenopathy, if you find you do EBV, you do HIV, and you start, if bone pain is there, you start suspecting leukemia, do a bone marrow, Brucella antibodies. Okay. If there is a lymph node, you start considering a connective tissue disorder or a malignancy. Look at the peripheral smear. Of course, bone marrow is a must, particularly in these days. When you think of MIS-C, we always tend to start IVIG and steroids. I think in such situations, you have to consider bone marrow for PU. Lymph node is accessible, you can do a biopsy and you can target the diagnosis. And of course, once you start thinking of a rheumatological disorder, you are going to ask for vasculitis test like ANA and your dsDNA, etc. And there may be clues like a low CRP and a high ESR, which could suggest in an adolescent female, particularly if there is albuminuria, multisystem manifestation, SLE. So your workup should be multidisciplinary, trying to rule out infections first, quickly ruling out malignancies, and looking at the possibility of autoimmune disorders. I think I'll ask some open question. I don't know if Ashwath and Ashwani are there. Jaydeep?
I'm here, sir.
Ashwath is here.
We'll start with Dr. Ashwath. Dr. Ashwath, do you use NSAIDs for fever? When do you use it? What NSAID do you use it? And how do you use it, Ashwath?
So I use primarily NSAIDs when there is a strong inflammatory component to the fever, sir. Like, let us say it's a septic arthritis or an osteomyelitis or there is a tender cervical lymphadenitis, I would prefer ibuprofen over paracetamol at the dose of 10 milligram per kg thrice a day for 3 to 4 days. Once the pain is inflammatory signs are down, once the abscess
I'm not asking for anti-inflammatory effect. I'm asking for fever, antipyretic. Do you use NSAIDs, and what NSAIDs do you use?
I use NSAIDs for fever, mostly for non-infectious fever, sir. So if it's non-infectious.
And what is your preferred NSAID?
If it is juvenile idiopathic arthritis, I would use naproxen, sir.
Okay. Dr. Ashwani, do you use NSAIDs for fever? I think he's not there.
We lost him again.
Jaydeep?
For fever, no, it's paracetamol only for fever. But I totally agree with Dr. Ashwath that if it's an inflammatory fever, then the question is different. Then we have to go definitely for NSAIDs. But for fever alone, paracetamol, because our main target for fever, not the inflammatory condition, is not to bring down the temperature, but to make the child comfortable. So paracetamol and as on when required, other physical measures.
Do you use mefenamic acid, Ashwath or Jaydeep?
No.
I don't even know the dose, sir.
Okay. Let me be very honest in telling you.
Yes.
I do use ibuprofen above 6 months of age for fever, not routinely. Okay, not routinely. If I know my patient well, patient is a very otherwise well child, okay, and they already have some ibuprofen, and they ask me whether they can give ibuprofen for fever or not, above 6 months. Only thing is I use a lower dose, 5 milligram per kg. In fact, if you look at the dosage of ibuprofen, it's 5 to 10 milligram per kg, only 6 hourly. Only for anti-inflammatory effect, you may have to use a high dosage of 10 milligram per kg. For antipyretic effect, is 5 milligram per kg. Only thing is, I may not use if there is the slightest suspicion of dengue. And I don't prescribe if the parents already say that after fever, the child's intake is very poor for fear of gastritis. At the same time, if you look at literature, ibuprofen is as safe as paracetamol. It's not a dangerous drug. In fact, there is enough information that even in asthmatics, even in atopics, ibuprofen is not contraindicated. It's tolerated as well as paracetamol, except for longer duration of action. It has not got many benefits over paracetamol. And I always prescribe ibuprofen in parents who are paranoid about fever, in whom I am worried they may end up giving too much of paracetamol and produce toxicity, right? Okay. Now, regarding naproxen is a much safer, amongst all the NSAIDs, naproxen is perhaps the safest NSAID in terms of renal effect, but it's not used for fever. It should not be used for fever. Mefenamic acid, I'm afraid it's not a good drug at all. Now to Ashwani, if he's there, or to Ashwath. Do you advise tepid sponging at all, Ashwath?
No, sir.
No.
The answer is a big no, sir.
You never advise tepid sponging?
No, sir. Advice to the contrary, always.
Okay. What about Jaydeep?
Yeah, I do advise, especially for older children. I do advise.
When do you give that? When do you give it? What advice do you give?
Yeah, because usually the viral fever, what happens if we advise paracetamol every 6 hours, after giving paracetamol within 2 to 3 hours, the fever starts to rise. Then the parents are very anxious and they go for a shorter interval and also higher dose. So I usually counsel them, when I advise paracetamol, I usually counsel them that if a fever recurs in between the doses, then you can initially start with the tepid sponging, wait for 6 hours, give the next dose.
How do you ask them to do tepid sponging correctly? Jaydeep?
Normal tap water, use normal tap water.
Tap water in December may be 20 degrees temperature. Will you use that in Delhi, or even 40 degrees?
Yeah.
Chennai tap water will be 30 degrees.
No, I always advise the water should not be very cold. So that's a normal room temperature is around say 30 degree, but that's 30 degrees. I do not mention
Which
at all.
patients you select?
say-
Which patients you select for tepid sponging, and how do you categorize?
See, see, infants, they will scream if the tepid sponging is done. But in an older
Then why give at all?
child, again with high fever coming at very, yes, sir?
Yeah, go ahead.
Yeah, children above 1 year, when the fever is recurring at very short interval, then the tepid sponging helps and it keeps the parents engaged also.
Okay, Ashwath, why you are not using tepid sponging? Why you are not using tepid sponging? Because I have again created a division. Dr. Jaydeep appears to favor tepid sponging. You are not favoring tepid sponging. Ashwath, your comments.
Sir, as we understand, temperature is basically elevated because of resetting of the hypothalamic thermostat. So by tepid sponging, I am bringing down the skin temperature. I am not bringing down the core body temperature. So core body temperature is what makes the baby child uncomfortable, and the child's risk of seizures or the metabolic demands are driven by the core body temperature. My tepid sponging, even if you take skin as a large organ, you cannot sponge the entire body. And it's going to be shortly. At that burning temperature, the water will evaporate and produce a transient drop in the skin thermometer temperature. The core body temperature is uninfluenced, and people who have had sponging, I have personal experience, it is extremely uncomfortable to have somebody apply a wet cloth on you when you're burning inside.
Yeah. I agree with Ashwath. Tepid sponging, I would say, yeah, it's non-pharmacological management. Yes, you should encourage. But I think there are a lot of problems in doing tepid sponging. One, it's very difficult to teach parents how to do tepid sponging correctly, starting from the temperature. And more importantly, you should do tepid sponging after a dose of paracetamol when the fever is coming down, not at the height of fever. When there is a rigor, if you put a cloth on the child, wet cloth on the child's rigor will worsen. Actually, it will have more discomfort. Third is that young children don't tolerate. Fourth is that parents really, in their panic, they really lose their cool. They don't do it correctly. In fact, I have known a doctor who used to go and keep the child in the shower whenever there was fever because of fear of febrile seizures. I think with all these caveats, that there have been a lot of debates. And the final consensus is that tepid sponging, though beneficial, is not recommended. In fact, if you go to the NICE guidelines, please do not do tepid sponging. That is what has been given. But if somebody wants to do tepid sponging, say non-pharmacological management, you don't want to give drugs at all, you want to be a naturopath, then in that case, you must advise tepid sponging correctly. Now to Dr. Ashwath again. Ashwath, do you treat fever differently in children with febrile seizures? You know, your parents with febrile seizures are a very, very worried lot. Fever means it is panic. Do you treat the fever differently?
So you said it rightly. I think more often than the child is the parents who need clobazam. I think they start going ballistic when the temperature doesn't come down and there's a demand for antibiotics or more powerful medicines than the tried and trusted paracetamol. I think I take the time out and tell them again, sit with them for 5 minutes and explain to them that it's a bit of a fatalistic view, if you want to say. A child who's going to have febrile seizures will have febrile seizures no matter what you do. So the height of the temperature is a very poor predictor of the chance of recurrence of a seizure, first time or a recurrence. So I would tell them, please give paracetamol, make the child comfortable, and if the child convulses, don't panic, wait for 5 minutes and use an intranasal midazolam spray and stop it. Just because the child has got febrile fits, I would not advise ibuprofen upfront or cycling paracetamol, ibuprofen, or still worse, give ibupara fixed dose combination or give mefenamic acid.
Okay. What about temperature chart, Jaydeep? Do you have one temperature chart which you give to the parents when you have child with fever in front of you for home monitoring? And when do you give? Do you give it routinely? And what is the temperature chart that you use? The hospital charts are very confusing. Dr. Jaydeep.
So it's a simple temperature chart. The time and the temperature definitely, I mean, try to give to all the parents. Most of the parents are quite educated and they can do it. And of course, with a column which mentions that when they are giving paracetamol, that also shows me the duration, I mean the interval, and also at what temperature they have given. They should not give below 100. So definitely I do advise that simple temperature chart.
Do you give it routinely or only in selected cases?
I ask in 90% patients.
What about Ashwath? What about Ashwath?
I would not do that routinely, sir. I'll ask them to keep a track of the paracetamol dose for each and every child. I tell them what is the maximum permissible dose and put 15 milligram lower than the maximum dose. So even though the textbooks say 50 to 60 milligram of paracetamol is fine, because in their parents, I believe that in their panic situation, they will tend to overdose. I tell them don't exceed 40 milligram per kg paracetamol, come what may. I said, if you're very anxious, you admit the child, keep him under observation, but please don't overdose. That is what I would say.
I have a temperature chart. I'm not showing it. I give a temperature chart where I ask them to measure 6 a.m., 10 a.m., 2 p.m., 6 p.m., 10 p.m. And I generally advise them if there is any distress or the temperature goes above 101, if you are worried, you give paracetamol. And I tell them not to give more than 5 doses of paracetamol. I usually ask them to give 10 to 15 milligram per kg of paracetamol. And my temperature chart actually contains the warning signs which I showed in the earlier slide. One last question.
So Dr. Ashwani sir has joined, sir.
Yeah,
Dr.
yeah.
Ashwani sir has joined. Ashwani sir has joined. Ashwani.
Join. Yes, we will start with Ashwani. Ashwani, please give an example of an unusual case of fever from your experience. And that's my last question to the panelists before we give the summaries. Yes, Ashwani. Some unusual case of fever. You must have seen lots and lots.
We had one 5-year-old girl, and the history was very different one, that she will have swelling of the elbow joints, and some antibiotics were given every time with fever, and that will respond, and in between she will remain well for 3-4 weeks. So she landed us with around 8 courses of antibacterials, and we got admitted her and studied a fever pattern. The fever was used not to be beyond 102 degrees, and when we started working up, it turned out to be a case of tuberculosis of thyroid.
Oh, very, very. Okay, what about Ashwath? Some unusual case before you wind up. Ashwath and Jaydeep, one each.
So last month we had a child, 4-month-old child, sir, was brought with history of fever, pain, irritability on moving the left lower limb. So when we did the examination, the mother said after all the trouble started after the 3rd dose of the pentavalent vaccine, which was given at the primary health center. So what we saw was diffuse redness and swelling in the left thigh. The hip and the knee joints were free. There was tenderness definitely on palpating the thigh region. There was diffuse erythema of the lower limb, and the counts were very high. The ESR was high, the CRP was high. There was a brisk thrombocytosis, and the X-ray showed a good periosteal reaction. So we did an ultrasound to see whether there was any periosteal, subperiosteal collection, and to our dismay or surprise or pleasant surprise, the ultrasonologist said that this is a subperiosteal collection. It looks like a osteomyelitis that is bursting through subperiosteal abscess, and please take up the child for a surgical debridement. When the surgeon went inside and saw there was hardly any pus, and the cultures was negative, and the child did not show any response to ceftriaxone cloxacillin even after 72 hours. So we went back to the pathologist and asked them, can you please process a sample faster so that we have a quicker answer? It turned out to be Caffey's disease. Okay. Till that moment, we didn't know that it could affect in the thigh asymmetrically. We've always been looking for it in the clavicle, the scapula, and the mandible. So that was a surprise.
Okay. Jaydeep?
Again, it was a 5-year-old girl who was having fever for 2 weeks. Initially, oral amoxiclav was given, then I was admitted in another hospital on day 8. And the report was hemoglobin 10, the total count was high, the CRP was high, the platelet was high. And the chest X-ray from outside shows some streaky shadows. Now, the child did not respond after 4 days of antibiotics. Then chest X-ray and blood test was also similar. There was no evidence of TB. USG was done. There was hepatomegaly, and the fever continued. So then the child was referred to our hospital, and many other investigations was done. Along with that, a CT chest was done because the child had some respiratory complaints, which again showed the streaky opacities. Now, at this point of time, which the parents did not reveal previously, that there was history of intermittent painful nodular skin lesions previously. And 2 times the child had blood streaked sputum also. So then the child was investigated for non-infectious causes of fever. The P-ANCA, C-ANCA were negative, ANA was negative. Bronchoscopy was more or less normal anatomy. The in between the nodular lesions in the shin recurred. So skin biopsy was taken and it showed vasculitis. So ultimately the diagnosis was ANCA negative small vessel systemic vasculitis, which is quite rare, and this was published also.
Okay. Now, in fact, I thought I should share one case which was discharged yesterday in my unit. This child had all features fitting in with EB virus infection. Had exudative tonsillitis, generalized lymphadenopathy, splenomegaly, upper airway resistance syndrome, mouth breathing, periorbital edema, lymphocytosis. But then outside, dengue, NS1 and IgM both were positive. He had lymphocytosis, mild thrombocytopenia. We repeated the dengue NS1, that was also positive. We confirmed it is EB virus infection. Simultaneously, child had features of both dengue and EBV, dual infection. That we are trying to look at false positivity of NS1 and IgM. NS1 false positivity doesn't occur in EBV. Well, IgM antibodies positivity can occur in other arboviral infection, malaria. So that child, of course, we did not give any treatment other than symptomatic measures. Child is better. So to summarize, I think my panelists would definitely agree that somebody was joking. Somebody was joking recently. Some student was asked, what is the most common symptom of COVID-19? He said fever. Then the lecturer corrected, it is not fever, it is fear. Fear is the commonest outcome of any fever. I think we should treat fear rather than treat fever aggressive as a symptom. There's no point in trying to read those numbers 103, 104 and give antipyretic after antipyretic. Like the
Dr.
culture
Bala,
of culturing. Yeah.
Dr. Bala, before you take the take-home messages, I have 2 observations which I would like to have your comments. Now, should we stick again the definition of 3 weeks of fever for pyrexia of unknown origin after every investigation? Because now few of the publications say that you stick for 7 days.
It doesn't matter at all, Ashwani, whether it is 3 weeks or 2 weeks. If you have done the basic workup, if you don't have a diagnosis, you call it FUO or PUO or prolonged fever. It's not going to make any difference. Your approach is not going to change just by labeling it as PUO. Your approach is going to be same. I think that's all semantics. It doesn't matter at all if you ask me.
And secondly, as a pediatric practice point of view, we should not talk about those fever. They are all like all different types of fever. They are classically seen only in adults, and I think we should take away the teaching.
Absolutely. That's correct. I think like the culture of culturing for typhoid fever and for urinary infection, the culture of temperature charting needs propagation. I think parents should be asked to be taught to record temperature correctly and document it correctly, and we should give them the warning signs. I think we should say a strong no to tepid sponging. In fact, tepid sponging in children with febrile seizures or without febrile seizures, I think has no place. Paracetamol or ibuprofen as a single drug is a good antipyretic. We don't have to treat aggressively. We have to treat the discomfort of the child rather than the temperature chart. Fever without localizing signs, as you could see with the differences among the panelists, is always, the Western protocols are very difficult to follow in practice. You have to individualize. but you should not miss serious infections, SBI. It's a medical emergency in infants, particularly below the age of 3 months. And I would say, I'm sure all of you would agree, UTI is the most commonly missed and messed up cause of short duration fever. An empirical antibiotic therapy, as pointed out by my panelists, in office practice for fever is rarely required as an emergency. And wherever it is required, you should do appropriate investigation, start the therapy correctly. If you follow the correct approach, there is no way you can go wrong. Finally, let us hope that with the discussion for 2 days, fever will lay a strong foundation everywhere for a national approach to fever, thanks to Fever Foundation of India. Thank you very much. Over to the organizers.
Thank you, sir. Thank you very much for the wonderful moderation for the panel discussion. And thank you, Ashwath sir. Thank you, Ashwani Sood sir, and thank you, Jaydeep sir, for the comments and clinical pearls. We are getting lots of comments in the chat boxes and everyone appreciating for the clinical pearls which you have been giving in the last 1 hour, sir. Thank you very much, sir. And over to Dr. Jagdish Sinappa, sir, for the comments.
Thank you very much. And today has been a wonderful day. We started off with, some little esoteric topics, but then came down to what is the basic things that every pediatrician should know about fever. And thank you very much, Dr. Balasubramanian and team, Dr. Ashwani, Dr. Ashwath, and Dr. Jaydeep, for clarifying all those simple things that everybody needs to know. Over to you, Krishna.